Good afternoon. Welcome to DCRI Grand Rounds. We're very honored to have Dr. Eugene Braunwald be our speaker today. Dr. Braunwald is the Distinguished Hersey Professor of Medicine at Harvard and the chairman of the TIMI study group. Dr. Braunwald did his training at New York University, undergraduate, graduating in 49 and medical training 52. At that time, he did his internship at Mount Sinai and fellowship, and then completed a residency at Johns Hopkins Hospital. He did additional training fellowship at Columbia University, and then went to the NHLBI, where he was the clinical director of cardiology. And he served there for 10 years, from 1958 to 1968. And when he was recruited to become chairman, the founding chairman of medicine at University of California, San Diego, and he served there for 4 years, and then was recruited to Harvard to become chairman of medicine at Harvard, which he served till 1996, and he was also the chief academic officer of the partners. He served as the chairman of the TIMI study group until now, and that's been very important for us because, like Duke and UNC, we look at DCRI and TIMI as a somewhat of a competition. Dr. Braunwald's research career is phenomenal. When he went to the NIH, he really studied cardiovascular physiology and heart failure, MI, and valvular heart disease, discovered really the neurohormonal hypothesis of heart failure, hypertrophic cardiomyopathy, and did a lot of work on the hemodynamics of valvular heart disease. He's published over 1,000 papers. He's been cited as a top cardiologist in research. The Nobel Prize winners in medicine voted Dr. Braunwald as the person who has contributed the most to cardiology, and he was the first cardiologist elected to the National Academy of Sciences. So without further ado, Dr. Braunwald.
Well, good afternoon, and thank you for inviting me to DCRI and to Duke, and I feel very much at home here. I have worked with many of you for years, and with some of you for a shorter period of time, and we enjoy a lot of collaborations. And I'm going to give this talk this afternoon on heart failure, which I'm going to try to outline some Duke-Brigham connections as they have built over the years. So this is going to be something of an autobiographical sketch. Can somebody get the lights, please? So as you heard, as you heard from Chris, I went to NYU Medical School and graduated in '52. Now, my professional life has been a series of terrific events. I've been very fortunate to have been in the right place with the right people at the right time, and that included my medical school training. Because while I was in medical school, there was no such thing as elective experiences. Electives were not part of the curriculum. But at NYU, we had an associate dean who introduced the concept of electives, and I believe, as I've been around the country and have served in a new school and an old school, and that it was either the first or one of the first medical schools that offered electives. That changed my life. And I became interested in cardiology, and I will show you who my mentor was and how he influenced me. But I want to take you back in time. Is this on? Yeah. I want to take you back in time to what cardiology was like when I was beginning my 4th year, because that's when I took the elective. So the cardiovascular mortality age adjusted, was in this country was 3 times what it is today. If you think about imaging, which we take for granted, there was a chest X-ray. There was no echo. There was no nuclear. There was no angiography, coronary arteriography, no contrast ventriculography. Cardiac catheterization, which is sort of a staple of what you do, there were 12 cardiac cath labs in the United States. 2 of them were at Bellevue Hospital, which is was the major teaching hospital for NYU, but it was also a major teaching hospital for Columbia. There were many, 3 medical schools at Bellevue, and 2 of them had cath labs, so it was an epicenter. There was no left heart cath. There were no CCUs. The concept of the CCU wasn't established until 1962. And the early mortality of acute MI was about 30%. I say about because when somebody came in by ambulance and died in the emergency room, which was very common, you didn't quite know how to count that person. So it was pretty bleak. What did the different conditions look like? Well, acute rheumatic fever was a big deal in the northeast of the United States. There were rheumatic fever hospitals. There was the one in New York that was affiliated with NYU Med School was Irvington House on the Hudson, and was a large, about a 200-bed hospital. And the House of the Good Samaritan was in the Longwood Medical Area in Boston and affiliated with Boston Children's Hospital. So active rheumatic fever was a very common condition, and therefore valvular heart disease was a dominant form. So this is the epicenter of clinical trials, and there were clinical trials had not yet been invented. In 1951, there were no. Everything was done on the basis of observation and the experience of my last 3 patients. There was no such thing as evidence-based medicine. If you read the textbooks of the era, they're just opinions. And there was not really hypothesis-driven clinical research. Arrhythmias were very common. All we had was quinidine and digitalis, and we know that both of these cause arrhythmias and probably cause them much more than they reduce them. And pacemakers had not yet been invented. The risk factor concept, the concept that there's something that predisposes a patient, especially to heart attacks, that didn't come along until Framingham in the 1960s. So myocardial infarction, which was the most common cause of death, was as if it came as a bolt out of the blue. People didn't know that that some people were more likely and other people less likely. Knew that it hit males, and it usually hit males in the most important years in terms of their family responsibilities. Males in their 50s, as opposed to now we're seeing many more women in their 70s and 80s. Cardiac surgery, the only operation that was done with frequency, in addition to ligating patent ductus and maybe fixing the coarctation in children, was closed mitral valvulotomy. Open heart surgery cardiopulmonary bypass was years away. The budget of the National Heart Institute was $200,000 a year, and the research budget of the American Heart Association was $40,000 a year. So that's a pretty sorry picture. So why would a young person be attracted to a field that was so backward? Well, there were three reasons. Number one, if cardiology was backwards, you should have seen some of the other specialties at the time. So everything is relative. But there were two sort of places that I felt you could get a little traction in. And one of these was, what about this whole hemodynamics? What about cardiac catheterization? That seemed like like something that you could work on, because, there were these cath labs, but they were they provided a lot of opportunities. And the third was a wonderful mentor, Ludwig Eichner, who was they didn't have divisions in departments at that time yet. The divisional concept developed in the 1960s. It certainly wasn't present in 1951 anywhere in the country. And Ludwig Eichner was a senior cardiologist, and he directed the cardiac cath lab, and he took me in for a 4-month elective and changed my life. He changed my life because of the kind of questions that he asked, which were hypothesis-driven questions. And they dealt with congestive heart failure. So I sort of cut my teeth on that, learned about cardiac catheterization. I didn't do any catheterizations as a student, but I was involved in the interpretation of the tracings. Cardiac catheterization was not a diagnostic technique at the time. It was a pure research technique. And it was only in later years that people began to use it diagnostically. So he excited me about cardiology, and the fact that I had observed catheterizations and had analyzed the tracings made me very aware of what was going on, and particularly of what was going on in cardiac surgery. And in adult cardiac surgery, as I said, it was closed mitral valvulotomy. Now, there was a guessing game about who should be operated upon. Remember, the surgery is finger fracture of the mitral valve, blind, and we couldn't measure left heart pressures. So it was done by using the stethoscope. There was no echoes to look at the mitral valve. And a lot of patients, in addition to having the classic diastolic rumble, also had systolic murmurs. And that presented a tough problem. So if you have systolic murmurs, well, isn't that what mitral regurgitation is? It was at that primitive level that we were operating. And yes, sometimes it was, and if it was, that was not good for the patient. It was an unnecessary operation to somebody who's very sick, and you know what that does. So, I got into studying valvular heart disease. So here are the 5 chapters, what I said, the 5 adventures that I have had and am continuing to have. and I will talk about 4 of these. I'm giving the other lecture on heart failure. So I'm not going to say very much about heart failure in this autobiographical discussion. So 1953, now I'm a year out of medical school, and I'm completing my internship, as you heard, at Mount Sinai, and this is at the time of the Korean War was drawing to a close, and I assumed that I was going to become an assistant resident and then maybe a senior resident. And my chief of medicine said no. He said, because you're going to be drafted in the middle of the year, and that's going to disrupt the schedule. So we're very glad. He said, you've done a great job. But he wasn't quite that strong. But he said, no, I think, as I remember the wording, is your work has been more than satisfactory. And there's no question that we would like to have you take your residency. But you're going to be drafted in the middle of the year. And this is not against you. I'm not taking anybody for a 1-year program when I think they have a good chance to be drafted. So I felt I was going to be drafted somewhere in the next few months. So how am I going to pass my time? Well, I'd had this experience in Bellevue in the cath lab, which had excited me, and I enjoyed cardiology as an intern. And I said, well, maybe I can work. Now, Mount Sinai had a cath lab. By that time, there were 15 in the country, and 3 of them in New York City. So the discussion turned around that we have to get into the left side of the heart. That was an unexplored territory. And that was a major effort because we've got to find out who has mitral stenosis, how severe is it, and who has mitral regurgitation, and should that prevent unnecessary surgery. So this is the first paper that I published in Circulation, which was in 1955, 2 years after this fellowship. And it obviously it's the hemodynamics of the left side of the heart is studied by simultaneous left atrial, left ventricular, and aortic pressures, particular reference to mitral stenosis. And please take note of, of this name, Mark Ravitch. I'll come back there. He was the cardiac surgeon. And now, what did we do? We measured the pressures. Mark Ravitch measured the pressures in the open chest. Now, and here, can you get that light off, down a little bit? Because, okay, that's fine. So you see a before and after tracing. I think you all recognize these pressures were all aligned with the manometer at the same sensitivity. And obviously, here's the left atrium. In black is the left atrioventricular pressure gradient across the mitral valve. Here's the LV. Here's the aortic pressure. And it almost looks like a diagram from a textbook of physiology. And then if you look at, this is after valvulotomy, you can see that the gradient is much reduced. Now that illustration, which came from the paper in Circulation, Dr. Ravitch insisted on having in the publication, even though it wasn't representative. I would say that of the 15 or so patients whom we studied, that was the best one. But in that paper, we have a couple that were more representative. But you know, we had to assuage the chief of cardiac surgery. So at least we began to get a handle on this. I'll leave the lights down. I then went back to Bellevue to get more training in hemodynamics. I said that there were two labs, one at NYU and the other one 4 floors away at Columbia. And Andre Cournand was the director of the Columbia division of Bellevue Hospital. And I was there the year before he won the Nobel Prize. It was an extraordinary experience. He was the father of cardiac catheterization, paper that he had published in 1941. And I think that the Nobel Committee at that point recognized what cardiac catheterization, what an impact that was going to have on understanding hemodynamics, etc. And he was a great mentor as well. By that time, I was doing caths and analyzing them. So here is a world figure. If we try to think about the lives that we lead now, the non-world figure lives. So here he was at the apex of clinical science, and he went to 2 meetings a year. There was no traveling around. There were no multi-center trials. There were no, he went to the American Society of Clinical Investigation meeting and the American Physiological Society. And he was there all the time. And he took maybe 3 or 4 days vacation a year. And the laboratory consisted of 2 fellows. And a group of very dedicated technicians and nurses. And that was it. And that was a big lab. Then I went to the NIH, as you heard, and I actually interrupted my clinical training by 4 years. I ended up at the NIH, and I came across Glenn Morrow, who at that time was he was, and was for the remainder of his life, the chief of cardiac surgery. He was one of Dr. Blaylock's residents, and he was a very close colleague of David Savaston, and my working very closely with Glenn introduced me to David Savaston, largely on a social basis. One thing that's interesting, you don't have many thoracic surgeons smoking. But wait a minute. At least in Boston, we don't have many. We know this is North Carolina. Anyway, now Glenn Morrow, when he took a postdoctoral fellowship, in thoracic surgery. Cardiac surgery wasn't really established as a formal subspecialty at the University of Oxford. And he worked for a very notable thoracic surgeon, Professor Graham Allison. And Glenn was over there for 2 years, and one of the things that he was charged to do was to do a lot of bronchoscopies, and there was a patient that he was assigned to bronchoscope with a huge bronchial cyst, and he was asked. At that time, it's rigid bronchoscopy only. Flexible bronchoscopy was like 25 years away. To drain that cyst. And he dutifully did that, and when he put the needle through the bronchoscope into the cyst, there was a huge amount of very bright red blood that came out. And of course, it wasn't a cyst at all. it was an enlarged left atrium. And so at Oxford they had missed the diagnosis of mitral valve disease. But this was an aha moment for Glenn. So when he came back and started the program at the NIH, he developed the technique of transbronchial left heart catheterization, which seems barbaric by today's standards, but it was sure better than opening the chest and sticking needles. It was sure better than what we had done. So you can see the enlarged left atrium. You can see it in the frontal projection here, and then in the lateral here. And he was very slick at this. You can't leave a rigid bronchoscope in a patient for more than a few minutes. And he did about 7 or 8 of these every Friday morning. And I helped 2 ways. I helped get the patient ready by doing the local anesthesia, and I also ran the recorder. But I had the best job of all, because it was Friday mornings, and he gave me the tracings to analyze. And then we met Monday afternoon when he got out of the OR, and we looked at the tracings together. And that was an incredible experience, because this was all new stuff. All new stuff. Dilated cardiomyopathy with high early and late diastolic pressures. All varieties of congestive heart failure, aortic stenosis, name it, was way beyond mitral valve disease. Of course, the focus still was on mitral valve disease. And I felt in the relationship that I developed with Glenn and that entire experience, it was like Lewis and Clark. And he taught me a lot of physiology, and he taught me actually a lot of cardiology, I have to admit. But we did a lot together on these transbronchials. Now, they were less than ideal because they were tough on the patients, and you couldn't, for example, have a bronchoscope in place and study the effects of a drug on hemodynamics. I mean, that was out of the question. So it was very important to try to get this into the cath lab and get it out of the operating room or the bronchoscopy suite. And Glenn was in agreement with that, because as his surgical experience increased, he felt that this was sissy stuff. Yeah. John Ross, who was a year behind me at the National Heart Institute, developed transseptal left heart catheterization. And it's an interesting technique which was pretty uniformly employed in the 1960s, and then fell by the wayside when retrograde caths were possible through a Seldinger needle, where you didn't need to cut down, because cardiologists are not good at cutting down on arteries. Bob Jones is laughing. And or more importantly, at repairing them after you pull the catheter out. So this was fine, but when the Seldinger technique came along, it paled. But it has had a tremendous revival, as you know. There are many, many, many more done now than were ever done in the 60s, because it's used in the EP lab in order to get into the left atrium. And it's also used for assisted circulation and a variety of other things. So one of these things that came up suddenly, fell down, was almost forgotten, and then has now revived into a second, even larger life. So this gave us the opportunity to really study valvular disease and to study the effects of drugs on the circulation, etc. My first wife, Nina, was in the cardiac surgical department, and she was the first woman heart surgeon, and she had a lot of firsts, and one of the firsts is actually seen in her hand here because she developed the first mitral valve, and it was the first successful valve replacement by whether you had X and Y chromosomes or double X chromosomes by anyone. And this became possible again through Glenn Morrow's mentorship. And so I think among the many things I learned from Glenn is I saw firsthand within my own family what somebody who aspires to have a role in medicine, how they need to be mentored. And, you know, this was not a field that people, that women were in at all. It was one of the last bastions, but he did a lot for her. And here's an example of, this is a paper published in 1965, and it shows actually the four people that I have now mentioned. By that time, mitral valve replacement was being done quite frequently. Now, one of the issues in selecting patients for mitral valve surgery in the 1960s was there was great fear of operating on patients who had an elevated pulmonary vascular resistance. It was felt that this was an irreversible change in the pulmonary vascular bed, the same as it is in many congenital lesions like ventricular septal defect or single ventricle, and that these patients were at high risk and there was no gain. Well, that was simply wrong. And here are 25 patients. Here are the results in 25 patients in whom the pulmonary vascular resistance was elevated before operation, and half of them were mitral regurg. They're all valve replacements. So the other half were mitral stenosis, the ones in blue, and you can see, with the exception of this one patient, their pulmonary vascular resistance, these were called back 6 months after the surgery, had all declined massively. And I would like to think that this paper was of some significance because people stopped using this pretty common feature in advanced mitral stenosis as a reason to prevent you from going for operation. So that was an exciting experience that we had, and I think this paper got widely accepted. We also had the opportunity in aortic stenosis, which of course came along, and the surgery for which came along later, for John and myself to do some natural history studies on patients who were not operated upon. And I think this pattern is pretty well known to you, where the patients have this long latent phase. This is survival on the vertical axis, and they do pretty well, and there are relatively few deaths. And then it's if they fall off a cliff, and which is the moment they become symptomatic. And so by the time we had prepared this paper, this was a long time of borning, but by the time we prepared this paper, aortic valve replacement had come along, and we said that we have to try to define this period before they fall off the cliff, before they develop severe symptoms, because by that time the ventricle is damaged. And that still remains challenging sometimes when we see patients with AS, but I think it's much simpler now because we have terrific imaging techniques, which of course we didn't have at that time. Well, I want to fast forward and what is happening to valvular heart disease. I'm not going to go through the recent everything recently, but I am very struck by the abilities of interventional cardiologists to this is known as in a dilated mitral valve ring to put 1 or 2 stitches in the center here, which certainly prevents this portion of the valve from ballooning back. Is called the Alfieri stitch. And of course now these clips can be placed. By transeptal left heart catheterization, by the way. And there is a reduction of mitral regurgitation, and obviously the same thing is going on with aortic valve replacement. My second adventure, hypertrophic cardiomyopathy. Well, in 1958, I catheterized. I was back. I'd done my completed my medical training after this long fellowship hiatus, which came about because I was refused a first-year residency in medicine. I then finished that at Johns Hopkins. Then I returned and was head of a cath lab. And I catheterized a young man who had a loud murmur in the what we would call a pulmonary valve area that radiated upward. And I found that he had a subaortic gradient of about 100 millimeters of mercury. Here is the pressure tracing, and you see the pullback from the LV cavity to the LV outflow tract to the aorta. So this is obviously subaortic stenosis. And we had our weekly cath conference, and I voted very strongly that he should have aortic valve surgery. Excuse me, excision of the subaortic membrane or incision of the subaortic membrane. As a matter of fact, we thought it was likely that this wouldn't need, certainly didn't need valve replacement, but that he should probably be done on cardiopulmonary bypass, which was just beginning to emerge. Well, an open heart operation in 1958 was one big deal, and at the NIH it was an even bigger deal. You know, there were like 40 or 50 people in the operating room, and I'm in the cath lab doing my thing when I get a call. Dr. Morrow wants you in the operating room immediately. And so I got somebody to finish off the cath, and I go up there. And Glenn is saying, "You really screwed up." Those were his words. "You really screwed up. He doesn't have any obstruction." I said, "What?" He says, "He doesn't have any obstruction." You know, I was in scrubs. He says, "Well, just just put a mask on and lean over. He said, look, I've got one finger in the left atrium and through the atrial appendage, and it's down through the mitral valve. And I've got another one, I've opened the aorta, and my two fingers are meeting in the middle of the left ventricle. There is no obstruction. You screwed up. And he was very tight. And he said, you probably are going to be responsible for this kid's death. Well, you know, when a surgeon goes to pieces. I mean, you've heard all the nice things I've said about him, but when push comes to shove, you know, they're all the same. No, they get very upset if a patient dies in their hands. I don't know what to say. I don't know what to say. I don't know what excuse to make or anything, so I decide I'm going to go back and downstairs, and so I'm slinking out with my tail between my legs. But then I had an interesting thought. I said, turned around and said, Glenn, if you get him off bypass, or he had arrested the heart with potassium citrate, which is a long story in itself, of how you can, the kind of cardiac arrest that was used and how serious it was. Then please stick a needle in the ventricle. There was a radial needle, and see if there is anything there. So he comes back about 3 or 4 hours later, looking totally exhausted, pulls me out of the cath lab a second time. He says, you know, when I got his heart started, he had a gradient of 100 millimeters of mercury. And we don't know what's going on. And fortunately, the young man recovered. He had a murmur. And Glenn and I would speak about this, of what the devil could be going on day after day after day. And finally, about a month later, he puts his arm around me. And, you know, we're best buddies again. Because I wasn't wrong, and he knows he embarrassed me. By the way, when I came down after that terrible mess, I called my mother. Who was very understanding. So now we're buddy again. He puts his arm around me, and he said, you know, Gene, I've been in medicine longer than you have. He was an old man. He was 36. I was 28. And, you know, sometimes you got to face the fact that sometimes you come across things in medicine that you simply can't explain. And you have got to move on. You have to move on, and because otherwise you get stuck, and you'll be frozen. And I said, I guess you're right, okay. And it was like that for another month, when exactly the same thing happened. Now, minus the calling me. I mean, a young man with a subaortic pressure gradient goes to the OR. Glenn operates on him. He doesn't find the subaortic membrane. But he does come down and say, you know, that heart was pretty hypertrophied. So we bring them back. Now, he also survived, fortunately. We bring both of them back 6 months later, recatheterize them, and measure the gradient. And this is what they looked like. Now, we didn't know what we were dealing with, but we felt that it was not the usual obstruction. So we gave it a terrible name, functional aortic stenosis. But it had a malformation characterized by resistance to left ventricular outflow without anatomic obstruction. And that was more correct than calling it functional aortic stenosis, because it wasn't aortic stenosis. But anyway, we published it in Circulation, just those two patients. And then they came flocking in just like crazy, because it was the beginning of open heart surgery, and there were a lot of people walking around with systolic murmurs, and we know that this is the most common single gene abnormality in cardiovascular disease. It affects 1 in 500 births. Big deal. And so we learned a great deal. There was a young surgical fellow, Ned Brockenbrough, and he discovered that the response to a ventricular premature contraction is that this sign of having a VPC, and then in the next contraction, the gradient goes up, which is what it would normally do in aortic stenosis, but the aortic pulse pressure does not rise. That means there was less blood ejected, even though the ventricle was contracting more vigorously. And that rang some bells. It became clear that patients, a lot of interesting work going on here with isoproterenol at the time. Henry McIntosh was the chief of cardiology. That there was a response of this outflow tract obstruction that was simply different from that existing in any other condition. And here we described nitroglycerin and the Valsalva maneuver. And I want to show you on this slide a scary, very scary tracing. This was published in 1964, as you can see. So here is the patient with what we now call IHSS. And we now, the best name probably, not probably, is HCM, hypertrophic cardiomyopathy. And you see that there's just the LV pressure is just maybe 5 or 8 millimeters higher than the peak brachial artery pressure. It gets nitroglycerin, and you see the arterial pressure come crashing down. Really scary, really scary. And the gradient goes from a gradient of 5 millimeters to a gradient of, 175 millimeters. So this is dynamic obstruction. What we did about this was very simple. We elevated the patient's legs. So nitroglycerin pooled the blood, made the heart smaller. The heart gets smaller, like after a VPC, and it expels, and the stroke volume goes down radically. Raise the legs, venous return increases, the heart returns to its previous position. So we learned a lot from that, and we also observed, although there had been some papers in the British Heart Journal of families with ventricular hypertrophy, but they were not studied during life. These were post-mortem studies. We began to map out the fact that this appeared to have an autosomal dominant transmission. So we're beginning to see this now as a genetic disease. And beta blockers appear. In '63, I was at a conference in London, and I was able to get a hold of some beta blocker. And I won't tell you how it came to the United States. I would probably be arrested. And you know, there were no IRBs at the time. The IRBs had not yet been invented. That's a separate story. But we gave these patients beta blockers, and we found that in a double-blind trial, this was the amount of exercise they were able to do, minutes of exercise, and we switched them between starting on propranolol. It was done in a random way that we would think was proper today. Certainly that wasn't the case 10 years earlier, but I think clinical trial methodology was beginning to evolve. And you can see that it didn't matter whether they got propranolol first or placebo first. They developed an ability to walk much further. Glenn, meanwhile, was working on surgery, and he developed an operation which really is myotomy / myectomy. So you see here this double-bladed knife that Glenn developed, and here is the bulging ventricular septum into the outflow tract, and he makes these two parallel incisions, and then using a rongeur, and then first blunt dissection, then a rongeur pulls this out. And this has been, and this is probably called the Morrow operation. And I think you all know about alcohol septal ablation. There are some in some medical centers who swear by one, and I think the other one is terrible, and vice versa. There was an interesting debate about this in one of the circulation papers about a year ago. What's the favorite here? Bob?
We have Andrew 1 in the back of the room.
Yeah.
Can tell you better than that?
Yeah. So how many? What's the ratio of myotomy, myectomies versus alcohol septal ablation?
It's predominantly still myectomies here.
Uh-huh.
I think about 30 per year are done
Yeah.
at this institution, and alcohol septal ablation being reserved for either patients who are poor surgical candidates or those that, for other reason, refuse to undergo surgery.
Yeah. Well, that's exactly where we are at the Brigham as well. So it's interesting. So heart failure, I'm not going to say anything about. Oh, I'm going to show you one slide in heart failure because I'm going to talk about that entirely, and that's the SAVE trial, which was a trial that looked at ACE inhibition, a trial that was done led by Mark Pfeffer, and there was a 21% risk reduction of total mortality. These were patients with LV dysfunction post-acute MI who were not in heart failure. And this seemed to extend the indications for ACE inhibition. Lipid lowering. The 4S trial was published in 1994, and that is really the landmark trial of statins. The 4S trial was conducted with simvastatin in patients who were post-MI and who had an LDL concentration that averaged 175. And we were convinced when that trial had begun, got underway, that trial was going to be smashingly positive. And it was. But we reasoned that that is going to be a small slice of the population. Maybe 3% or 5% of post-MI patients had LDLs that was that high. And we wanted to study the same thing, but in patients with, quote, average, I'm not saying normal, average LDLs. And that was the CARE trial, which we did with pravastatin. And it was positive as well. And it was interesting to see that nothing happened for 2 years. And it's, if somebody threw a switch, and the two curves began to separate. So that was an interesting development. We then went on with Chris, under Chris Cannon's leadership in TIMI, in the Prove It, TIMI 22 trial, to look at the same dose of pravastatin that we had used in the CARE trial, and compared it to atorvastatin 80. So if you were to superimpose the control curve on that, it would probably look like this. And then 40 brought it down here, and atorva brought it down further, at 25% relative risk reduction. And one of the things that we were interested in, now this goes back, now we're 5 years ago, was, can low be too low? Can you have too low an LDL? Because we were now beginning to hit patients for the first time in the Prove It trial to have LDLs that were under 40, and even a couple under 30. So there were 25% that were under 50, which was pretty unheard of, and 10.5% under 40, which was really unheard of. And we looked very carefully at these patients, and they exhibited no ill effects. People said, oh, you're going to, when you gave 80 milligrams of atorvastatin to somebody whose LDL is less than 100 to begin with, you're going to lyse their central nervous system, all their myelin sheaths, whatever the cholesterol is supposed to do in the brain. Well, nothing happened. Of course, nothing happened because we know that all of us during our developmental years have LDLs in the 40s and the 50s, and some of us grow up to be people. Primitive populations. The hunter-gatherers have LDLs in this range. So I feel even more strongly after this that you can't be too rich or have too low an LDL. We're now engaged together as a joint DCRI TIMI effort, working on the Improve It trial. One of the goals is to take the LDL even lower. And here we're using Simva and ezetimibe. And I believe that we're getting LDLs about 10 milligrams per deciliter lower than we did in the Prove It. We're blinded, so we can't really, I can't really say that for sure. Myocardial ischemia and infarction, the last chapter, but unfortunately for those of you who have honest work to do, it's the longest one. So when I came to the NIH, I worked in the laboratory of cardiovascular physiology that was led by a brilliant scientist, Stanley Sonhoff. So he is the fourth mentor that I want to mention today. So Eichner, Cournant, Morrow. So you're going to be wondering, what is this guy talking about? He just has gone in detail about what he did with Glenn Morrow and how he, analyzed these tracings and so forth and got involved in the cath lab and so forth. Well, there is an explanation. And the explanation is that Glenn Morrow's working hours were from 6:45 to 3:15. And Stan Sonel's working hours were from 3:30 until whenever. So I was a full-time member of the cardiology team dealing with transeptals and stuff like that, and transbronchials, and I was a full-fledged member of the physiology laboratory under a very demanding mentor. So what we began in 1955 was a study that at that time, I have to say, did not appear to have any clinical implications. Now, I don't think that that's anything that's bad. That's what you do in science, and sometimes there's a clinical application. A lot of times there isn't. But it seemed like an important physiologic problem to examine the determinants of oxygen consumption of the heart. What drives that? How much energy does the heart need to carry out its various functions? And we devised this very complicated, this was, you have to imagine this in situ in the dog. And in order to carry out these experiments, here was a Stalling resistance that changed afterload. It was a reservoir of blood, and here's preload could be changed here, heart rate this way. And then there was another dog hooked up in parallel. SD meant support dog. And this allowed us to independently vary the relevant parameters. And after 12 years of working on this, obviously not full-time because I'm showing you other stuff, these three appeared as the most important determinants of myocardial oxygen consumption, responsible for about 90%. And these others were there, but they didn't cost much energy. Now, so in the 60s, I had my own laboratory and was responsible for the cardiology, clinical cardiology program. And in one of the labs, we studied oxygen consumption, as I showed you, a continuation of what Stanley Sonhoff had inspired. And in another lab, we studied control of the circulation by the carotid sinuses. And carotid sinus nerve stimulation, here the carotid sinus is here. If you stimulate these nerves physiologically with more pressure or electrically, there is reflex vasodilatation, there is reflex reduction of heart rate, and there's reduction of cardiac contractility. These are the three determinants of myocardial oxygen consumption. They are the biggies. Now, what have I got here? University of Rochester, 1967. This was a terrific trip. So I was like a visiting professor there in Rochester, and had 2 very interesting days. And they're calling a cab to take me to the airport. And a young surgeon shows me he said, I want you to come to my lab. I'm doing some stuff that might interest you. And this is Seymour Schwartz, who later edited the #1 textbook of surgery after Sabiston. And who was very distinguished chairman of surgery at Rochester. And he had a group of dogs in his lab in whom he had produced hypertension. He produced hypertension by unilateral nephrectomy and wrapping the other kidney in cellophane, which at that time was a very good way to produce very resistant hypertension. Antihypertensive medication wasn't, not very much. And he had pacemakers on their carotid sinus nerves. And he showed me the fact that these dogs' blood pressures were controlled. And in flying back to Washington, it occurred to me, well, maybe we could put electrical stimulators on carotid sinus nerves in our patients. And if they felt that angina was coming along, they would press the external button, send the signal transcutaneously, and reduce their oxygen consumption. And I came home and I asked Nina if she, could do that. She said it's a piece of cake. But she went to the lab. She was excited enough about this to go off the surgical service for about a month and worked out the techniques of not injuring the carotid sinus nerve, but yet still being able to do it. And actually, we put that in. She put that in, and it was a reasonably successful. And here is a picture of one gentleman. And here you see the external pulse generator. Here's the button that he presses. And then you can see this is the antenna. You can see the incision and the antenna. The receiver was there, and the wires ran to his carotid sinus nerves. Now, we told our patients not to use the stimulator if they had unusual pain, unusually severe or unusually long, and because we didn't want to vasodilate patients who were undergoing myocardial infarction. Well, sure enough, this gentleman, about 6 months after he had this put in, he was getting good responses for his angina. I was very happy. Had an MI. He came to the clinical center. I saw him in the unit. People began to work him over. I noticed he had the stimulator on. And I said, you shouldn't do that, and I'll help you turn it off. And I turned it off. And I came by about a half hour later, and he's doing okay, and the stimulator's back on. And I turned it off, and this was repeated several times. And finally, I gave up, and I took the stimulator away. I said, I'm going to give this back to you in a couple of days. I want you to get well, then you can use it again. That evening, I looked at the ECGs, and when the stimulator was off, when I turned it off, his ST segment had risen about 3 millimeters. They really looked like tombstone STs. And when he was smart enough to turn the stimulator on, they came down and were isoelectric. And so he obviously did the experiment. He was much smarter than I was. He said, I want that stimulator on. And that gave us the idea that maybe an infarct is not fixed. Maybe it isn't sort of a yes or no. Maybe you could possibly intervene. We moved to UC San Diego, as you heard from Chris, and we got our dog lab going very rapidly. We were fortunate enough to have a large satchel, in which at that time we could fill that with money as we went across the country. And we carried out a number of experiments, and this is the key one. And it's factors influencing infarct size following experimental coronary occlusion. This is in the open chest anesthetized dog. You can see, Peter Marocco, unfortunately deceased, was a research fellow. John Kekjes was from Norway. Some of us are working with him in lipid trials now. Bert Sobel, we all know. Jim Covell, John Ross, and myself. And we felt that we were able to manipulate the size of an infarction, at least in the dog. And this was the conclusion in that 71